Good evening, sir. My teachers, my colleagues, my friends, Professor Baheda, Padma Shri Professor Baheda, Professor S.K. Jindal, all DMs in the country are his students of and Dr. Baheda's Professor K.B. Gupta, sir. I welcome on behalf of Indian Chess Society North Zone first virtual conference with Saroj Super Speciality Hospital, Jaipur Golden Hospital, and IMA Rohini Zone with Pulmonary Foundation. IMA Revenue Zone is a very active organization, and today in panelists we have our president of IMA Rohini Zone, Dr. Naveen Rana, and Dr. Manjusha, which he was discussing. She is a gynecologist, but she is a dynamic secretary of IMA Rohini Zone, so that maximum people should learn about the basics of asthma, how you diagnose, how we treat. So, with this short introduction, I request Dr. Aditya Chawla, organizing secretary of this virtual conference, to please start the proceedings.
Thank you, sir. So, respected teachers, colleagues, and my dear friends, I welcome all to be there for the first North Zone virtual conference from today till 25th July. I am indeed very happy to welcome all the stalwarts who are the patrons of this conference and are the chairmen of their respective zones, namely Professor D. Beheda from Chandigarh, Professor D. Jindal from Delhi, Professor K.B. Gupta sir from Haryana, Rohtak, Professor Pravesh Paul sir from Jammu and Kashmir, Professor J.K. Samaria from UP, Professor S.K. Katiyar sir from UP, Professor Suryakant sir from UP, Dr. Ajay Singh from Punjab, Dr. Malay Sarkar from Himachal Pradesh, Dr. Girish Sindhwani from Uttarakhand, Dr. Ajeev Goyal from Delhi, and Dr. Professor Arun Madan from Delhi. So first I welcome all the doyens, and then I will request Professor D. Baheda as Chairman ICS to say a few words, and then I will proceed with Dr. K.B. Gupta, sir, the Chairman of ICS Haryana, and teacher par excellence and PGIMS Rohtak to say a few words. And I will be inviting, I welcome Professor D. Baheda, Padam Shri, former Director PGI Chandigarh, now HOD Fortis Mohali, Department of Chest. If I read sir's biodata, it will be in a 3 A4 size paper. Welcome, sir. I welcome Professor K.B. Gupta, sir, and head of who is professor and head of Department of TB Chest, PGIMS Rohtak, alma mater of my father, Dr. Rakesh Chawla. He was registrar when sir was a lecturer. Welcome, sir. He has always been a very sincere advisor to dad. I welcome Dr. S.K. Jindal, sir. He has been former HOD and Director of Department of TB Chest of PGI Chandigarh. All the DM students who have passed from under him. He himself is a very big stalwart of this chest faculty. I welcome Dr. Ajeev Goyal, sir. He is the chairman and senior consultant in Jaipur Golden Hospital, RGCI. He is a wonderful, kind person, a par excellence teacher and class interventional pulmonologist. Welcome, sir. Professor Arun Madan, sir. He is professor in HOD Medical College, Hindu Rao, Delhi. Wonderful person, member of editorial board of Lung India, a leading chest specialist in Delhi. Welcome, sir. And in the end, I will welcome Professor Rajendra Prasad, sir, who is a BC Roy awardee from President of India. There is no award which he has not been awarded. I am sure he will be in the line for the Padma awardees. Past President ICS, he is ex-professor and head of KGMC Lucknow, present professor and head of ERA Medical College Lucknow. Welcome, sir. Now I request Professor D. Baheda, sir, to speak a few words, sir.
So thank you Aditya for those kind words. Dr. Rakesh Chawla, Professor Jindal, Professor K.B. Gupta, Professor Rajendra Prasad, and other friends, because it is very difficult to name everybody. So at the very outset, I am very thankful to Dr. Chawla, Dr. Rakesh Chawla. I should say Dr. Rakesh Chawla par excellence. I think he has managed and organized this mega scientific event. It is not an exacerbation if I say it is a mega scientific event, and that is how Rakesh Chawla is. So he's also with us in the Indian Chess Society as one of the governing body members. Of course, he is the chairman of the North Zone of the Indian, Chess Society. So I think he's always a very good organizer, always interested for scientific activities. He has been doing it. So again, Dr. Chawla, I'm very much impressed that the way you have organized this event. It is a long 5 days and covering important topics in the field of respiratory medicine. The 2 days are devoted for asthma, one is for COVID infection, then interstitial lung disease and COPD. I think it is not the other important thing which I have noted that he has gathered all the stalwarts of the country, persons to the stature of Professor Jindal, Rajendra Prasad, and all the names Aditya has already said. I know, as you know, it is one of the very important goals of the Indian Chess Society is to propagate the chest diseases in the country, the science in the country. We all know that lung diseases, they are gradually, the things have changed, the orientation has changed. The country has got, nearly 4 crores of cases of bronchial asthma. If you see 6% of children and around 2% of adults. And similarly, COPD, the past report was again, the statistics was published by Professor Jindal. And then the Salvage analysis that shows we have got the COPD that increased by 2 times, between 1990 and 2016, from 28 million to 55 million. You can understand the enormity of the problem. Of course, going all the way is the master of all chest diseases is the COVID, of course, and very rightly, Dr. Chawla had kept COVID as one of the thematic discussions. I think it is tomorrow. Dr. Chawla, it is there tomorrow, so it is very right. And again, this will be an added burden or added challenge to the respiratory physician. Not during the acute phases of the COVID, also the post-COVID scenario, which many of us are facing. And that again, we are going to face for how many days or for how many years, I do not know about that. So it is a very timely initiative, Dr. Chawla. And again, I could see many younger friends. That is another thing which I like to highlight, Dr. Chawla. He has included many younger people. I could see many young faces, young faculty here. And if you go through the agenda and the speakers, so it is a very nice mixture, and it is only, I could say, it is only Chawla can do it. Rakesh Chawla, I always say that. It is Rakesh Chawla can do it. It is well done, Rakesh Chawla. We are very proud of you. On behalf of the Indian Chess Society, as the president of Indian Chess Society, I appreciate and I express our sincere thanks for this mega event, and then discussing these issues. But only one more thing I like to tell, ladies and gentlemen, I think again, don't forget about TB. TB is coming in a very big way. There are many issues. I think Dr. Rajendra Prasad is just laughing. Just before this conference, I was just with somebody. Of course, the data is not yet discussed. With some international agency, I was just discussing something. New is again coming up, so maybe within the next 2-3 days it will be public. So what I am trying to see for our country, particularly the youngsters. Yes, we have got now many more exciting areas in the field of respiratory medicine. You have intervention pulmonology, you have critical care, you have got lung transplant, XYZ, many things. But please don't forget, don't give it away to others from your hands. TB is being taken over by people who have got no idea about TB, let me tell you. I have got no hesitation telling that. It is again the fault of, it will be again after 10 years, 15 years, 20 years, you people will be, the future generation will blame you people. So please come forward, and it is your specialty, and please work for that. So with these few words, Dr. Chawla, again, thank you and congratulations for your great endeavor. Thank you. All the best.
Thank you, sir. Now I request Professor K.V. Gupta, sir, to speak a few words.
Good evening, sir, to everybody, all my teachers and seniors. First off, thanks to Aditya for inviting me and giving me this honor to just say a few words on this occasion. First of all, I want to congratulate Dr. Rakesh Chawla for organizing such a wonderful 5-day mega event. Dr. Behraj already said this thing. This is a very big mega event, scientific event, which is going to be held under the chairmanship of this is Dr. Chawla. Dr. Rakesh Chawla is an alumni of our department at PGI Masrotak. And when he said, when he was joined the department, I was working as a consultant, joined as an assistant professor. No doubt he's a very eminent pulmonologist, having a good interest in the interventional pulmonology, and also having some mind, this innovative mind. He has made some very many innovation in the field of pulmonology, especially the glue therapy. I can remember this thing. And apart from being in the practice in the cooperative hospital, then he has the very good academic interest also. He has organized so many conferences, Dr. has said this thing, so many conferences and this webinars, seminars also for the being in the academic interest. And apart from that, he is a very good human being also, very straightforward person and helping man also. And but good quality is that he is respecting every senior as his teacher, and this is giving the good respect to all the teachers. Now his son, Dr. Aditya Chawla, he's also a pulmonologist, and he's doing a very good job in the field of the pulmonology. He passed from the SRM Bareilly, and of course there's a great cooperation of Dr. Chawla's wife, Dr. Kiran. I know personally all the family, so that I'm mentioning this thing, and the good team behind him for the success of the conference, the Gaurav Chaudhary and the Ashish Sinha, this thing. Dr. Behra has rightly said, only Chawla can do it. I agree, only Chawla can do it, as he is doing also. Regarding Professor Behra has said about the TB, really it is in our mind. We have discussed with Chawla also, and we are planning next month also from the Haryana chapter, probably this webinar on the tuberculosis exclusively, by the discussion with the Manoj and our secretary, Dr. Dhamija. So very soon I will plan also. I mean, this is my mind, because my area of interest is more in the tuberculosis also. Then my sincere respect to all my senior teachers who have joined me as a patron, Padam Shri Professor Digambar Behra, Professor S.K. Jindal, Padam Shri Dr. Guleria, Professor S.K. Katyal, who was my teacher when I was a student at the GSBM Medical College, Kanpur. And Professor J.K. Samaria is also my senior, 1 year senior to me, one batch. He did MD from the BHU and I did from the Kanpur. Then I pay the thanks and respect to my colleague also, Professor Parvez Kaul, Professor Surkhan, HKUNC Lucknow, Dr. H.J. Singh, Dr. Rajiv Goyal, and also Professor Arun Badan and Professor Mulay Sarkar. And also one of my students had joined as a patron in this conference, Professor Girish Singhani, who did under this MD in my department under my supervision. Now, friend, the program is very, you can say, meticulously made with the academic interest. And Professor Chawla has rightly said, he has chosen all the galaxies of eminent galaxies in the field of pulmonology for all of the country as chairperson or the speaker. To name, my students are also joining as this chairperson, Dr. Mano Manchanda, who is in the Faridabad, Dr. Sushil Dhamija at Bhiwani, Dr. Srikant Sharma at Bhiwani, and also Palomi Chatterjee. Now, today's speaker, and also I must mention the Tariq Mahmood, who is HOD in the Medical College Allahabad, then my senior in the Kanpur, Nadeem Arsad, and also our friend Sandeep Nair. Now, and other also, to which I forget the name, but I should mention this thing also. Other chairpersons also, this Dipendra Rai and this Surisha Gupta, who are in the Ghaziabad now at Agra, then Yogesh, Prasant, then this Chandramani, Hitesh, Naveen, and this Manjeet Singh Goyal. So now this topic covered by our speaker today is very eminent speaker in the field of pulmonology, Professor S.K. Jindal, who is just by my teacher, and Dr. Rajiv Goyal and Dr. Manoj Goyal. So just I am not entering the academic part. Dr. Behra already just highlighted this academic part. So just to cut it down and to start the academic session, I just thank and welcome all the persons on this conference and thanks everybody for joining this conference. And thank you, Dr. Chawla, again and his team. Thank you very much.
Thank you, sir. Thank you, sir, for so many kind words, sir. Now I request Professor Rajendra Prasad, sir, to say a few words, sir.
Thank you, Aditya. All the giants in the pulmonary medicine, I must say, Professor Jindal, Professor Behra, Professor K.V. Gupta, Rakesh Chawla, and others. I know Dr. Rakesh. I used to say that Rakesh is really a very great organizer. I still remember when I was in Patel Chess as a director, and he did bronchology conference with the late APG Abdul Kalam Saab, and he got even my bronchoscopy book inaugurated by him. And he is in habit of doing all conferences. I still remember all the Respicon he used to do every year in Delhi. So, and Rakesh Chawla is also, I know him as an innovator also, like Dr. K.V. Gupta said about and Dr. Behra said about the glue therapy and other things. So he's always very, very active, and he did a lot of interventional bronchology and other things also. He's in mind. So he has thought a program which is well thought, and what I agree with Dr. Behra that education in tuberculosis is, I was discussing like one of the speaker today is Manoj Goyal, who has been my student. Rather bronchoscopy, he was start bronchoscopy in KGMC when I was there. So his beginning was from that, and now I know that he has gone to a very high place. So many of our students are doing like this. Adit also, I know him. He's a young coming up chest physician and interventional bronchology. He's going on the foot of his father Rakesh Chawla, and my best wishes. So I hope this conference would be a great success, and I wish this conference a great success. Thank you very much, Rakesh and Aditya, for giving me this opportunity.
Thank you, sir. Thank you very much, sir. Now I request Dr.
Just
Gaurav to invite the
Aditya,
chairperson.
I want to pay my sincere respect to the Professor Rajendra Prasad. I forget that actually, only I thought he is not joined. He is my teacher. I pay my respect with folded hand.
Thank you, K.V. Gupta.
Thank you, sir. I request Dr. Gaurav to invite the chairpersons now. Gaurav? अनम्यूट करो गौरव अपने आप को.
हाँ, driver sir.
Gaurav, you are not audible. Gaurav, you are not audible.
उनको ट्रेनिंग नहीं दिया था लगता है.
So I can start. I can start.
Ashish, you unmute and start introducing the chairpersons.
Okay, sir. Thank you, sir. Sir, it is both my honor and pleasure to be a part of this conference which is being held under the aegis of Indian Chess Society and by Dr. Rakesh Chawla. Today, I would like to take this opportunity to invite the chairperson for tonight's session, Dr. Parvez Kaul. He is the.
Hello, Bhaiya.
Hello. Am I audible, sir?
You are audible.
Yes, sir. Okay, sir. So I would like to invite Dr. Parvez Kaul. He is the head of the department, Sher-e-Kashmir of Medical Sciences. Dr. Nadeem Arshad, senior pulmonologist, Asthma Allergy Center, Gorakhpur. Dr. Sandeep Nayyar, senior director and head of the respiratory department, BLK Max Super Speciality, New Delhi. Dr. Manav Manchanda, associate director, head of the department, respiratory medicine and critical care, Asian Hospital, Faridabad. Dr. Dipender Rai, additional professor of head of pulmonary medicine, AIMS, Patna. Dr. Hitesh Agarwal, head of the department, ENT, Saroj Hospital. Dr. Rajiv Garg, professor and head of the department, SGPGI, Lucknow. Dr. Poulomi Chatterjee, assistant professor, Shahid Hassan Khan, Mewati Government Medical College, Nalhar, Haryana. Dr. Sushil Dhamija, director, Dhamija Chess Hospital, Bhiwani, Haryana. Dr. Sunisha Gupta, professor and head of the department, FH Medical College, Agra. Dr. Naveen Rana, Hospital, Khanjiwala, New Delhi. Dr. Jogesh Sharma, professor and head of the department, respiratory medicine and medical college, Guwahati, Assam. Dr. Prashant.
आवाज पता नहीं क्यों नहीं आ रही. I don't full सब चीज on है.
Dr. Prashant Kumar Singh.
You are audible.
Okay, sir.
Dr. Prashant Kumar Singh, consultant pulmonologist, Ruban Multi-Speciality Hospital, Patna. Dr. Shivkant Sharma, senior consultant and director, Kant Hospital, Bhiwani. Dr. Chandarmani Punjabi, head of the department, pulmonary medicine, Mata Chanan Devi Hospital. Dr. Tariq Mahmood, head of the department of respiratory medicine, Prayagraj. Dr. Manjusha Goyal, senior consultant, Fortis Hospital, Shalimar Bagh, sector IMA Rohini. And Dr. Saurav Yadav, associate professor and head of the department, GMC Medical College, Firozabad. So should I also call the speakers?
Let Gaurav invite the speakers.
Okay, Gaurav, you please invite the speakers.
Thank you, sir. Sorry for the audio problem. Am I audible now?
Yes, you're audible now.
Very good evening, everyone. All the stalwarts of the pulmonary medicine in the country. Myself, Dr. Gaurav Chaudhary, on the behalf of organizing committee, I invite my first speaker, Professor S.K. Jindal, sir, former professor and HOD, pulmonary medicine, PGI, Chandigarh, currently medical director, Jindal Clinics, Chandigarh, a doyen of respiratory medicine in India, and a very well-known name in the country for his book, Dr. S.K. Jindal book. Everyone knows it. So I invite Dr. S.K. Jindal, sir.
Well, thank you, Dr. Chaudhary. Honorable chairpersons, I can see very eminent people sitting here on the dais or off the dais at their homes, you see. So I am very thankful, especially thankful to Dr. Chawla and Dr. Behra, the president of ICS, for giving me this opportunity to speak on this very important webinar, on asthma. I have been assigned the topic of phenotypes of asthma. Can you see my slide here?
No, not.
I have to do it again, Mr. Okay, I'll do that actually.
Yeah.
Okay, thank you. So I won't take much time in talking about asthma in general because the topic here is very specific, the phenotypes of asthma. Bronchial asthma, Professor Bera has already said, it's a kind of very common disease and the burden is quite high. In fact, the global burden is quite high and the Indian burden is also significant, you see. Although the data is mostly localized, but around 2.5 to 3% of adults in the general population, you see. These are not clusters in the hospitals, general population, and more than 5%, some people say 5 to 10% in children. So that is a very kind of high burden of a disease, and the annual economic cost of asthma is also almost $60 billion annually. In fact, when this was calculated, it was roughly 56, but now it would be more than $100 billion or so. Asthma is a chronic inflammatory disease where there is immune system balance gets unbalanced, you see, in asthma developments, and we all know this kind of Th1 and Th2 type of kind of immunity which maintains a balance normally, you see. The Th1 being a protective immunity and Th2 kind of the allergic diseases. It is kind of disease specific immune disturbance, you see. So whenever this balance gets disturbed, one or the other problem is likely to happen, whether it is allergic or infective or mixed or so on. You see. Now, as far as asthma is concerned, there have been very rapid changes in the concepts about its definition, about its development, and then obviously about its diagnosis and treatment. You see. Earlier, you see, only about a few decades ago or a century ago, it was believed that it is a homogeneous disease where there is an involvement of mast cells and eosinophilic domain and inflammation is there, and the disease responds very well to corticosteroids, you see. And by and large, the severity was based on airflow obstruction. Now the concepts of its pathogenesis have changed significantly because it's now known that it is a heterogeneous multidimensional disease and there are multiple phenotypes with different underlying molecular mechanisms. So in a way we can say that asthma is not really one disease anymore. It is either a group of diseases or it is a syndromic manifestation of airway obstruction and so on, you see. So in fact, some of the concepts are still evolving. And now it is also believed that the determinants of disease severity is not only the airway obstruction, see. That of course is there, the functional impairment due to airway obstruction, but in addition, it also depends what is the likelihood of exacerbations and what is the natural history of the disease in a particular patient. I suppose those are also the important factors which determine the severity of asthma. So asthma is a syndrome. There are multiple reasons to believe that. One, I have already talked that there is a kind of heterogeneity of asthma, different phenotypes which are based on atopy or allergic predisposition. Then the phenotypes can also be based on the pathology, which is different in different groups. Therapeutic phenotypes, because it responds differently to different groups of drugs, you see. So we can say that there are multiple ways of doing this, of classifying this heterogeneity, you see. Then, of course, it is not one disease. We also know that there are a lot of overlaps of asthma with diseases like COPD, obstructive sleep apnea syndrome, metabolic syndrome, and so on. And then there are other conditions like ABPA, exercise-induced asthma, aspirin-induced asthma, etc. So in a way that there are multiple kind of reasons which can lead one to believe that it is a syndromic diagnosis. So what are the real asthma phenotypes? phenotype is just a kind of a very simple English word, which means the observable characteristic or morphological characteristic of a person, of a disease. In fact, this was the term used earliest for plant phenotyping or zoological phenotyping and so on, you see. It is just the appearances. How does one look like, you see? That is what, or even we can say different groups of people in the world look differently. So there are different phenotypes, you see. This phenotype may have no direct relationship to a disease process. I think that is very important to understand, that it is only an observable characteristic, you see. So we can say that the recognizable or distinct clusters of demographic features, clinical characteristics, lung function, impairment, etc., etc. So that is what is a phenotype, you see. So it is a very superficial type of classification, you can say. Then there are, of course, endotypes and genotypes. We will not go into those details for the time being. Endotypes is when you talk about the distinct entities which may be present in a cluster of phenotypes. So different phenotypes may have same endotype, or one phenotype may have different endotypes also. So each endotype in a way has a specific mechanism. Here what is important is the pathophysiological mechanism, and genotyping, as you can see, means the type of inheritance. That, of course, for asthma is very complex, because it is not a purely genetic disorder. It is only a partial disorder, which we cannot say that it is autosomal recessive or sex-linked. So, and asthma is one disease which depends upon genetic and environmental factors. So it will take many more decades perhaps before we can say the genotypes of asthma. Why do we do phenotyping? Basically, phenotyping is done to better understand the etiological mechanisms of asthma, to identify specific causes of asthma, and to guide the development of new therapeutic measures that can be effective for most asthmatics, or at least for asthmatics belonging to that group, that phenotype. So it would enable us better management and prevention in both, in fact, globally. In fact, not only in the high-income countries, but also in the middle-income and low-income countries. Commonly, we employ two types of approaches. One is one-dimensional, where we do a simple classification based on one characteristic, like age of onset, early onset asthma, late onset asthma, atopic asthma or non-atopic asthma. Then we can say on clinical features or trigger related, many say allergen induced, trigger, exercise induced. Some people say stress induced, psychological asthma, and aspirin induced, so on and so forth. It can also be based on demographic features or on pathological features. So this is a very simple kind of classification, which may not be necessarily useful for us as far as the treatment modalities are concerned. Then we use the multi-dimensional approach, which is a kind of class analysis, where multiple factors are taken into consideration to define a single or multiple phenotypes. Multi-dimensional approach is relatively difficult to analyze, but that is what is most kind of helpful in achieving our objectives. So these are combinations of clinical characteristics which link biology to phenotype, and it is a statistical based process which we commonly, or the best is cluster analysis, where you can analyze the different clusters of asthma to put into one or the other cluster. So these would help us to kind of clearly understand the molecular pathophysiology in a group of asthmatics. So we can then, of course, define the clinical characterized cohorts of asthma. It is a large scale kind of analysis is to be done, and with different kind of focuses. So here there are, in a way, you are classifying asthma patients on multiple characteristics who are behaving similarly. And they are plotted according to the relative expression of symptoms and inflammation. And there are two axes. I'll show you the one diagram which is very commonly used, and you must have seen a lot of articles here. You see where we can say that that there is a kind of relationship, or then based on those relationship between inflammation and symptoms, we can say whether it is a concordant disease or it is a discordant disease. The summary is that the one size does not fit all patients. I think that is one term which very frequently has been used. You see, that is what is concordant versus discordant. And here on this axis are the symptoms and inflammation, eosinophilic inflammation. So if the groups are going like this, you see, that is what is a kind of linear relationship, which is the based on this, that if more inflammation, more the symptoms, more inflammation, more the symptoms. So that is what is the concordance. You see, on the other hand, there would be discordant asthma, where, for example, this type of asthmas who have discordant symptoms, who have more symptoms, but very little inflammation. You can say the inflammation is just here, you see, all these groups. And same is true for this group, you see. This group has a lot of inflammation, but their symptoms are not as significant as should be there based on the degree of inflammation. That is what is a very important kind of diagram to understand the relationship between these two kind of between discordance and concordance of asthma. So there are different clinical asthma phenotypes. In fact, I have already said that the clinical, it could be allergic, late onset, aspirin exacerbated, aspirin induced, and so on. And then there are inflammatory. I'll come to these very soon. These are the inflammatory pathways in asthma. That there is allergen-induced asthma here, which kind of once it crosses the epithelium, it activates the mast cells, which produce the IgE, and also it also produces through other pathways the different cytokines, especially IL-4, 13, and they act differently, produce IL-5 and IL-13, and then cause kind of allergic inflammation. You see. Then, of course, there is a pathway here which is a non-allergic, where there are a lot of pollutants, microbes, glycolipids, etc. They also enter the cells and act through differently, and they would cause kind of neutrophilic asthma. So what happens in a way, it is either the allergic eosinophilic asthma or the neutrophilic asthma, which is more, you can say here, inflammatory, but it is non-allergic inflammatory, you see. Then, of course, there is a mixed type, which is kind of non-allergic eosinophilic asthma, where the features are kind of mixed, you see. I'm sure that you can understand that such a complex mechanism happening in the body cannot be just a pure kind of this inflammation, and this is a pure inflammation of this kind. So that doesn't happen in the body, you see. So what is type 2 inflammation? Partly I've already said that, which is almost 50% of severe asthma patients are characterized by type 2 inflammation, where IL-4, IL-5, and IL-13 are more importantly involved, and they are also activated by viruses, bacteria, and other irritants, you see. So these are what are the classification of clinical phenotypes. The asthma, the three most relevant clinical phenotypes are, for example, asthma with frequent and severe exacerbations, which is of allergic variety, and then asthma with a fixed airflow obstruction or non-allergic variety. I won't go into the details here for lack of time. I'll just talk that the allergic and non-allergic phenotype, because they are the most commonly clinically relevant for us, you see. In allergic variety, you know that the age of asthma onset is younger. They have a trigger. Usually seasonal pattern is there. Food allergy may be there, or other allergies may also be there. current or family history of atopies are more common, like urticaria in particular, you see. Smoking history is less common, and they're less severe, less fixed airway obstruction, or FE1 is not commonly less than 80% of predict. On the other hand, the non-atopic variety, which we commonly see in the elderly population, they do not necessarily have a trigger. They may start at late in the life. They do not have a simple seasonal pattern. Food allergies and other allergies are not as common. So these are the non-atopic phenotypes, you see. So if we see the kind of summary of phenotypes, that is what is more commonly, that one is eosinophilic or the Th2 types, and then there is non-eosinophilic types, you see, like Th2, non-Th2 types of phenotypes. You see, they're the late onset, and they also have multiple sub-phenotypes, which we now do, obesity related. And I mean, people go on doing different clusters depending upon the different behaviors or characteristics. So I think this is a field which keeps on changing. The important point for us to know is that most of the severe asthma has a very different phenotype, you see. They are what we generally call, that's why we generally require kind of phenotyping to be done. And you know that what is severe asthma is therapy resistant asthma, or asthma which requires treatment with guideline suggested medications for GINA steps 4 and 5 asthma. In a way, they require all the drugs required for control of asthma, and yet they may not be controlled, like high-dose inhaled corticosteroids, LABA, leukotriene modifiers, the theophylline, and so on. And they require systemic corticosteroids for more than 50% of the previous year. So asthma which remains uncontrolled despite the optimized therapy as above. So that is what is severe asthma. I mean, severe asthma itself is a separate topic, and I think I can see in the program that there is a separate session for severe asthma. I'm just introducing it here because basically it is because of severe asthma that the concept of phenotyping came in, you see. So severe asthma has a lot of burden because I think what is important here to understand is that 90% or more have normal daily activities impacted. So their daily activities are impacted because of the asthma, including going to schools or going to work and so. And there is a 10 times higher risk of hospitalization compared to patients with uncontrolled asthma. In fact, increased mortality is therein, and it accounts for a majority of asthma costs, you see, because most of the costs for asthma are required for hospitalization, intensive care unit, etc. So that is what is required for severe uncontrolled asthma. So it has basically the severe asthma is responsible for a lot of clinical burden. A lot of these patients are not only sick, they have a lot of anxiety, there is impairment of quality of life, and they rely on oral corticosteroids with frequent complication and secondary complication of steroids, including diabetes, osteoporosis, and so on. You see. These are commonly recognized phenotypes of severe asthma, like the severe allergic phenotype, severe eosinophilic phenotype. I have already introduced both these things to you in my earlier slides, but then there are, I think, severe asthma with physiological impairment. That is another group which has been sometimes identified, though not a very well described as yet. And the severe neutrophilic phenotype, of course, is a very important. So these are the three most important: allergic, eosinophilic, and neutrophilic. Then there are multiple small groups as well. The exercise-induced asthma itself may be a separate phenotype. The obesity-related asthma, smoking-related asthma, neutrophilic, and even polygranulocytic asthma is they have been suggested by different investigators as different phenotypes. I mean, they are identified, but there is no clear-cut kind of classification which I can give you for the phenotypes, you see. These are what I've already said, that there are a lot of phenotypes. The late onset, we have already talked. And then there is fixed airflow obstruction when there is long-standing asthma with fixed air. I mean, that is what some people call as kind of the remodeled asthma, you see, that with passage of time. And many of these patients are grouped as ACOs, the asthma COPD syndrome. You see, what is really underlying mechanism that is not really known. We are not going into those details here, but it is enough to say that there is a group of asthma where there is a fixed airflow limitation which occurs over a period of time, you see. Obesity asthma is a very important phenotype, especially in children, because unless you really take care of obesity, asthma does not get cured, you see. And that is a very big issue in pediatric asthma in particular. These are the two most commonly understood in routine clinical practice, eosinophilic and non-eosinophilic. Eosinophilic characterized by airway and systemic markers of eosinophilia, subepithelial fibrosis, and they are steroid responsive. On the other hand, non-eosinophilic are characterized by absence of eosinophilia and subepithelial fibrosis, and they are poorly responsive to corticosteroids. So there are several important questions that help the assessment of a patient for diagnosis of the phenotype. One should first ask the age of onset of asthma, whether it is early onset or late onset. I have already talked the differentiating features in the two groups of asthma. What are the most important symptoms? Wheeze, cough, and because there can be multiple other causes of both these things, you see, you all know. So one should exclude those causes. When do the symptoms appear and does this influence treatment? Sometimes, for example, symptoms appear on exertion, usually require more relief medications, etc. So these are important questions to be asked. And before we make a diagnosis of severe asthma or severe asthma phenotype in particular, we have to exclude the other things, you see. Has the patient linked his symptoms to a specific exposure, etc. I think. Do we need a biomarker? That is the one important question. No universally accepted biomarker that is easy to use can be really identified. You see, whether it is eosinophil count or it is sputum eosinophilia or it is IgE. So one has to use different kind of a compromise with different kind of biomarkers. Exhaled nitric oxide is easy to measure, and increased levels may imply an upcoming exacerbations, you see. So that is one simple thing, but the other being very difficult routinely, you see. These are the important, for example, measuring eosinophils in clinical practice. Sputum eosinophils are the most accurate ones because they predict the response to steroids, but it is a time-consuming, labor-intensive, and not readily available at most of the places. So sputum eosinophils are not commonly done, you see. On the other hand, peripheral eosinophils are the most widely available tests, and they are very simple to use. In fact, that doing blood eosinophilia is not a big business, a big deal, you see. So one can really assess. And the other thing, as I said earlier, is the fraction of exhaled nitric oxide. And it is a very important measure of eosinophilic airway inflammation, and it tells you about steroid responsiveness. And it also helps to identify asthmatics who are possible candidates for treatment with a biological agent, you see. And I think this is a very important figure here, the graph here, which was done association between pheno and blood eosinophilia in uncontrolled asthma. And you can see here that there's a very nice relationship between these two things, you see, the blood eosinophils and FeNO. So the conclusion was that the blood eosinophils and FeNO can accurately predict eosinophilic airway inflammation in uncontrolled asthmatics. That's why, so normally we routinely, in clinical practice at least, not in experimental studies, but these are the two things which are commonly done, the blood eosinophils and exhaled nitric oxide, and they can very well predict the eosinophilic airway inflammation. And I have already told you these things in the questions which should be asked, and that is how we'll kind of evaluate severe asthma, difficult asthma patients. First is to confirm the diagnosis of asthma, because a lot of other mimics of asthma, COPD, eosinophilic lung disease, then interstitial lung disease, and other diseases. So I won't go into. Then, of course, is the other contributing factors like non-adherence to treatment, poor inhaler technique, the presence of triggers, and comorbidities. They are very important. So you should exclude. Once you have excluded all these things, you see, incorrect diagnosis and these things, then we assess the phenotype and perhaps endotype. Endotype is not really assessed routinely, and that then of course one can go with the targeted treatment of severe asthma. And I won't go into these details of phenotype targeted therapies because they have now become available, whether it is severe allergic asthma, eosinophilic asthma, or neutrophilic asthma. And then these are the specific kind of phenotypes where chronic airflow obstruction, recurrent exacerbations, and so on. So some treatments are specific to these, but this is very commonly, these are the three commonly identified phenotypes, and the targeted treatments should be done. And that is what constitutes the basis of personalized medicine or the targeted therapy, you see, where the treatment is individualized in a way. If we consider this, in fact, one can say that the treatment for asthma is no more a general treatment of asthma, which is the basis of treatment, but severe asthma in particular and some phenotypes of asthma in particular require personalized therapies, you see. So in conclusion, I would say that the phenotyping clusters of asthma are identified based on clinical and or inflammatory parameters. Stepwise evaluation for severe asthma phenotypes include confirmation of diagnosis, associated conditions or comorbidities, complications, other complications, adherence and compliance to therapy, technique of therapy. All these things come in this adherence and compliance. And then, of course, check the biomarkers like IgE, FeNO, etc. for phenotyping, and depending upon these, we go to the individualized phenotype-based treatment approach. And thank you very much for your patient listening. Thank you.
Thank you, sir, for enlightening us. Such a complex topic and very simply explained by you. So there is a paucity of time, so we will be taking all the questions at the end of the talk. So I would like to invite our next speaker, Dr. Manoj Goyal, sir, HOD and Director, Department of Pulmonary Medicine and Critical Care and Sleep Disorders, Fortis Gurugram. He will be speaking on the topic management of asthma with special reference to COVID-19 on the GINA 2021. I would like to invite Dr. Manoj Goyal, sir. Sir.
Thank you very much, and my warm regards to all the stalwarts here. It's a great honor for me to be in the company of such stalwarts and key opinion leaders of the country. And I thank Dr. Chawla for giving this opportunity. Not very easy to speak after Dr. S.K. Jindal, but it was a lightning presentation, very well grasped by all of us, and I really congratulate and appreciate him for this wonderful lecture that he just delivered. It was very informative and very simple. I mean, just about the complexities of difficult asthma very nicely. So I'll be I'll be covering a burning topic of this time. We are having an unprecedented, pandemic of COVID-19, and we know that COVID-19 primarily affects the lungs, and it causes many pulmonary complications: pneumonia, ARDS, pulmonary embolism, secondary infections, pneumothorax, pneumomediastina. So there is a concern. The concern amongst the physician, the pulmonologist, is about asthma. And as Dr. Jindal just talked about, there is a huge burden of asthma patients. So there is a concern how COVID-19 affects the asthma patients. So there are many questions. Are asthmatic patients at high risk of developing COVID infection? Are they at high risk of exacerbation due to COVID infection? Is the increased risk of mortality due to COVID infection in asthma patients? And what about biologicals, this specialized therapy, the targeted therapy these patients may be receiving? What do we do with these patients? What do we do with this therapy if somebody develops, COVID-19 infection? So there are many questions which are there. So I would like to address these questions in this talk over 15-20 minutes with a special reference to GINA 2021 guidelines, which have been recently released. So the first question is, are asthmatics at higher risk of COVID-19? And to answer that, a systemic review was published in Allergy, Asthma and Clinical Immunology in 2021. And the authors in this meta-analysis systematically reviewed all the reports of COVID-19 published since its emergence in December 2019 to June 2020. And they looked into the description of asthma as a premorbid condition which could indicate its potential involvement in disease progression.
निखिल बस बहुत बढ़िया.
And the authors in this meta-analysis found 372 articles and described 161,271 patients who were diagnosed with COVID-19 infection. And the authors reported a premorbid condition of asthma in 2,623 patients, which accounted for only 1.6% of all the total patients of COVID infection in this cohort. So out of total 161,000 patients of COVID, only 2,623 patients had underlying asthma as a premorbid condition, which was about 1.6%. So in this meta-analysis, the authors concluded that as the global prevalence of asthma is 4.4%, either asthma is not a premorbid condition that contributes to the development of COVID-19, or the clinicians and researchers are not accurately describing the premorbid condition of asthma in COVID-19 patients. But as we've learned and experienced in the last 2 years in COVID-19 patients, we do not get too many patients of asthma, coming with COVID-19 infection, especially in the hospital who get admitted. The two most important COVID conditions have been hypertension and diabetes, and of course the cardiovascular involvement. But asthma and COPD have really not been found to be the premorbid condition in our experience over the last 2 years, especially the patients who were admitted in the hospital. So next question, does asthma increase the mortality of patients with COVID-19? So a systemic review and meta-analysis was published in International Archive of Allergy and Immunology in 2021, very recent publication. And the purpose of this systemic review and meta-analysis was to explore the literature and collect data comparing the mortality of coronavirus disease in patients with and without asthma. So that was the objective of this meta-analysis. And the authors could zero down to 5 retrospective studies which met the inclusion criteria. And this meta-analysis of data from 744 asthmatic patients, 8,151 non-asthmatic patients indicated that the presence of asthma had no significant effect on mortality. So the mortality outcome was no different in asthmatic and non-asthmatic patients in this meta-analysis. Another important observation was that there was no difference in the duration of hospitalization and the risk of intensive care admission between asthmatic and non-asthmatic patients in this meta-analysis. So the authors concluded that asthma as a comorbid condition may not increase the mortality of COVID-19 patients. And this is what has been the experience of most of us in the recent times. The other question is, what is the impact of COVID-19 on patients with asthma? And this is the largest study which was published in European Respiratory Journal. The objective was to understand the impact of COVID-19 in patients with asthma. And they used the big data analysis and artificial intelligence and analyzed the clinical data from patients with asthma from January 1 to May 2020. The study was done in Spain. It was a large cohort of 31,000 patients of asthma. And out of these, only 1,000 patients, that is around 1.41% patients suffer from COVID-19. So again, as you can see, the incidence of the prevalence of asthma in COVID-19 patients was found to be significantly less in this group of patients. But another interesting finding from this meta-analysis was that the patients in this study was that the patient with asthma and COVID-19 was significantly older, 55 versus 42 years, predominantly female, spoke more frequently, and had higher prevalence of hypertension, dyslipidemia, diabetes, and obesity. So the important thing is that asthma patients who have got comorbid conditions, other comorbid conditions, are more vulnerable group to get infected with COVID-19, and this was clearly demonstrated in this study. The authors have also evaluated the role of inhaled corticosteroid, and it was an important finding that the use of inhaled corticosteroid was lower in patients who required hospitalization due to COVID-19 as compared to non-hospitalized patients. That was 48.3% versus 61.5%. So as of now, what this is, the result shows that less use of inhaled corticosteroid was more responsible for hospitalization and acquiring COVID-19 infection. So in a way, the inhaled corticosteroid seemed to be protective against acquiring the COVID-19 infection in asthmatic patients. They also looked at the data of the patients who were on biologicals. So there were 865 patients in this cohort who were on biologicals, and they were taking them regularly. And what they found that in this group of patients, there was increased severity at the ear, nose, and throat level. So they basically had ENT symptoms, upper respiratory tract symptoms, but their hospital admission rates due to COVID-19 was rated low, that is 0.23%. So the severity of disease from the lung point of view was not very high. They just had more of the upper respiratory symptoms rather than the lower respiratory tract infection and more severe disease. So the authors concluded that inhaled corticosteroids and biologics are generally safe and may be associated with a protective effect against severe COVID-19 infection. So the point comes, does asthma provide protection against COVID-19? So, some of the scientists believe that there is a particular inflammatory environment in the bronchi and the alveoli of the asthmatic patients, which could lead to a reduced expression of SARS-CoV-2 receptor and the ACE2 receptors, which may render asthma patients protected from the infection. Then a couple of studies, published, one in 2002 and 2020, showed that IL-13, a cytokine which is involved in eosinophilic recruitment to the bronchial epithelium, is capable of reducing ACE2 expression in bronchial epithelium, which could be again protective against the COVID infection. Now, what do we know about the treatment of asthma during pandemic? So there have been some studies which have been published. Of course, the quality of the literature is not very great, which has been there since the pandemic has started. We don't have a very high quality literature or the papers coming up. So in asthma, COVID also, we don't have too good of literature, but whatever we have shows some important findings. So coming to the role of inhaled corticosteroids, many studies have shown that the inhaled corticosteroid may decrease both ACE2 and TMPRSS2 gene expression on respiratory epithelial cells, decreasing susceptibility of SARS-CoV-2 viral binding receptors on respiratory epithelium. So again, ICS could be protective because they are decreasing the ACE2 and TMPRSS2 gene expression respiratory epithelial cells. A couple of authors have also reported that inhaled corticosteroid alone or in combination with bronchodilators suppress the coronavirus replication and cytokine production. An in vivo study published recently, 2020, showed that ciclosinide, which is an inhaled corticosteroid, suppresses the human coronavirus replication in human cultured cells. Another in vitro study has shown that formoterol glycopyranum and a combination of formoterol glycopyranum and budesonide have inhibitory effects on coronavirus replication and cytokine production. Coming to Montelukast, a study by Bozak showed that the rate of COVID-19 infection was significantly lower in the population of elderly patients with severe asthma taking Montelukast as compared to a similar population not taking that. So again, they found that montelukast possibly had some protective effect. Khan et al. Found that COVID-19 positive patients that were treated with montelukast experienced significantly fewer events of clinical deterioration than those not receiving treatment. So another study showing that montelukast could be having some beneficial effect against COVID infection in asthmatic patients. Now, many patients are on asthma immunotherapy. So what they have found is that AIT treatment in asthmatic patients leads to a desensitization effect and immune tolerance, which may be protective against cytokine storm occurring in severe COVID cases. So possibly AIT also has a protective effect against the severe COVID cases. The AACI statement suggests that AIT treatment can be continued in asthmatic patients without clinical symptoms of COVID-19 or recent exposure to SARS-CoV-2 virus. However, it is recommended that the asthma immunotherapy may be temporarily interrupted or stopped if patient becomes infected with COVID-19 until the infection is also temporarily. AIT should be stopped if the patient gets infected with COVID-19. Now, coming to the GINA guidance, which are published in April 2021, these are very simple, guidelines and very useful for the physicians, the pulmonologists, and all the people who are treating asthma. Very simple to understand and implement. So the question is, are people with asthma at increased risk of COVID-19 or severe COVID-19? The answer is no. People with asthma do not appear to be at increased risk of acquiring COVID-19. Systemic reviews have not shown an increased risk of severe COVID-19 in people with well-controlled mild to moderate asthma. So that is important. If the asthma is well controlled, then chances of having increased risk of COVID-19 is less or minimal in asthmatic patients. Secondly, are people with asthma at increased risk of COVID-19 related death? The answer is no. Overall, people with well-controlled asthma are not at increased risk of COVID-19 related death. But again, the caveat is the asthma has to be well controlled. That is very, very important. What are the implications of asthma management? This is a very important aspect. It is very important to continue good asthma management. The idea is to maintain good symptom control, reduce the risk of severe exacerbations, and minimize the need of oral corticosteroids. And this can be done by following the GINA guidelines appropriately in your patients. Have there been more asthma exacerbations during the pandemic? The answer is no. In 2020, many countries saw a reduction in asthma exacerbations and influenza-related illness, and this is what has been our experience. Our OPD attendance of asthma patients and the patients coming with asthma exacerbation in the emergency department has significantly reduced over the last 2 years. And the reason are not precisely known, but maybe due to hand washing, mask, and social and physical distancing, which these patients are following, and that could be a very important reason for decrease in the number of patients coming to the hospital who have got asthma. Now, COVID-19 and asthma, about the medication, it's very important to advise patients to continue taking their prescribed asthma medications, particularly inhaled corticosteroids, according to the GINA guidelines. And the patients who have got a severe asthma, and if they are on biological therapy and oral corticosteroid, then they should be continued regularly. Are ICS protecting COVID-19? We just described this in one study of hospitalized patients aged more than 50 years with COVID-19. ICS use in those with asthma was associated with lower mortality than in patients without an underlying respiratory condition. So ICS use could be protective in COVID-19. For the small number of patients who have got severe asthma and who are on maintenance oral corticosteroids, these maintenance oral corticosteroids should be continued, because stopping the OCS in such patients could suddenly deteriorate these patients and could be dangerous. So whatever add-on therapies are going on, the maintenance or oral corticosteroids going on, they should be continued as per the routine practice in these patients of severe asthma. The asthma action plan is a core issue in the GINA guidelines, and it's very important that we make sure that all patients have a written asthma action plan, advising them to increase control and reliever medication when asthma worsens, and they should take a short course of oral corticosteroids whenever appropriate for a severe exacerbation, generally 30 mg of oral corticosteroids for 3 days can be started by the patient on his own if he develops any increase or worsening his symptoms. Coming to the nebulizers, the GINA guidelines suggest we should avoid nebulizers wherever possible to reduce the risk of spreading virus infection. Pressurized meter dose inhaler by a spacer is preferred, except for life-threatening exacerbation. One can add mouthpiece or mask to the spacer if required. As far as the pulmonary function testing with spirometry is concerned, again, avoid spirometry in patients with confirmed or suspect COVID-19, or if the community transmission of COVID-19 is occurring. This is what we had done in the recent time. And always follow aerosol, droplet, and contact precautions if spirometry is needed. Better to consider asking patients to monitor PF at home if information about lung function is needed. What about the vaccines? Have COVID-19 vaccine been studied in people with asthma? The answer is yes. Many types of COVID-19 vaccines have been studied and are being used worldwide in asthmatic patients. Are COVID-19 vaccines safe in people with allergies? In general, the allergic reactions to vaccines are very rare. The vaccine should be administered in a healthcare setting where anaphylaxis can be treated if it occurs. So this is what we advise: a patient of asthma should receive, vaccination in a healthcare setting rather than, in a community setting, which is also, being practiced nowadays. The question is, are COVID-19 vaccines safe in people with allergies? Well, these vaccines should not be administered to patients with history of severe allergic reaction to polyethylene glycol or any other vaccine ingredients, which is a very well-known fact. So at present, based on the risks and benefits, GINA recommends that COVID-19 vaccination should be given to all the people of asthma. About the influenza vaccination, remind people with asthma to have annual influenza vaccination as a routine. A gap of 14 days between COVID-19 vaccination and influenza vaccination recommended by CDC. So this is something that we need to tell our patients that if there is, one of the vaccine which has been taken, then they should maintain a gap of at least 2 weeks between the next vaccination. About the COVID-19 vaccination biological therapy, the GINA suggests that biological therapy and COVID-19 vaccine should not be given on the same day so that adverse effects of either can be more easily distinguished. Generally, we know that biologicals are quite safe, except maybe for omalizumab, which can cause severe hypersensitivity reaction in 2 out of 1,000 cases. But otherwise, other biologicals are quite safe. But the guidance is that we should avoid both the vaccination and the biological therapy on the same day. So to summarize, patients with well-controlled asthma, important thing is patients with well-controlled asthma are not at risk of acquiring SARS-CoV-2 infection. There is no increased risk of exacerbation of asthma reported due to COVID-19 last year. Patients with well-controlled asthma are not at higher risk of death by COVID-19. Patients with asthma should restart or continue their prescribed inhaled corticosteroids plus long-acting beta-2 agonist maintenance therapy. It is safe to continue using oral corticosteroids during the COVID-19 pandemic if it is indicated, and patients should continue to use biologicals to manage severe asthma. Patients with asthma should not use nebulizer inside a healthcare facility, but they can use their home in a close surrounding. And patients with asthma should receive seasonal influenza and COVID-19 vaccines. Thank you very much for your patient hearing.
Thank you, sir, for updating us on this very hot burning topic of GINA 2021 with special reference to COVID-19. So moving ahead, I would like to invite our next speaker, Dr. Rajiv Goel, sir. He is HOD, Jaipur Golden Hospital, Department of Pulmonary Medicine, Critical Care and Sleep Disorders, Jaipur Golden Hospital, a renowned interventional pulmonologist, and the Director, Rajiv Gandhi Cancer Institute, Delhi. Dr. Rajiv Goel, sir.
Gaurav, can you allow me to share my screen, please?
Yes, sir. You have shared your screen, sir.
Okay, so
yes, sir, it's visible.
Is my screen visible?
Yes, sir, yes, very well visible.
All right, so at the outset, let me thank the organizers for inviting me to this meeting. I have been given the task of speaking on pitfalls of inhaler therapy for asthma. And since we are lacking in time, I am going to cut it really short. One way of cutting it very, very short would be to say that there are no pitfalls of inhaler therapy in asthma, but that would be a clear overstatement. So basically, there are pitfalls, and we will be talking about them, in due course. So inhaled therapy has been around for a very, very long time, and we know that the uh, I mean, as early as 2000 BC, there were reports of datura being used for as a treatment for asthma because of its anticholinergic effect, and then Romans used the hot water springs because they thought that the water and the steam could cure some of the respiratory illnesses. And but in the more modern age, let us say that basically, if you trace the uh, history of inhaler therapy in India, you find that the first inhaler which was introduced in India was the autohaler, which contained isoprenaline, a beta agonist, and then subsequently salbutamol in about 1976, and then all the others that we are very familiar with now, beclomethasone, budesonide, ipratropium, fluticasone, then the combinations, the LABA and the LAMA combinations, etc. And so, and then this has been actually going on. So this is a rather old slide, but you know that the we've come now to the once a day ultra LABAs and ultra LAMAs, and that's where inhaler therapy rests at present. So there are a lot of variations. There are a lot of various kind of options which are available to the patient. The main I think advantage of aerosol therapy in asthma, and that is the reason why it has completely sort of taken the asthma world by storm, is the fact that the inhaler therapy promises to deposit the drug directly at the local site, and by doing that, it makes sure that there is a faster onset of action. The lower dose of medication is required, much lower dose, almost 40 times less than the oral dose, and with much less side effects. So for all these reasons, where you have a drug which is acting quickly, which is acting very specifically at the site where it is intended, minimizing therefore the side effects, and the fact that a much lower dose is required, makes inhaler therapy the choice mode of therapy for most patients of asthma. And therefore, the success of the therapy basically rests on being able to, put the aerosol into the area where it is required, which is actually the airways of the lung. And how much of that dose can be delivered will actually decide the efficacy of what you're trying to do. So that is where the success of aerosol therapy for asthma and COPD rests. Now, if you look at the deposition pattern of the drug, you find that basically there are few things which actually can, cause a, you can say, problem or can hinder the deposition of the drug adequately. One is there may be issues with the device. Second, there may be issues with the aerosol which is formed. And thirdly, there may be, issues with the patient factors and the technique. So we will be talking about each of these to see where the pitfalls lie, so that when we are prescribing treatment for a patient of asthma, we are aware of these pitfalls and we can therefore individualize the therapy according to the patient and have success in our treatment. Now, if you look at let's look at the aerosol part. So you find that if you look at the particle size of these aerosols which are deposited in the lung, and you find that if the particle size is more than 5 micron meters, you find that there is no clinical effect. And if the drug will usually be deposited in the oral oropharynx, and if it is absorbed, it can be also cause some systemic absorption. But particles which are more than 5 micrometers, they usually will not have much of clinical efficacy. It is the 2 to 5 micrometers which are microns which are actually efficacious and have a clinical effect because they are deposited in the airways. And again, if they are less than 2 microns, they again have no clinical effect because they will go inside the lung and then come out and will not be deposited in the lung at all. So you are targeting therefore this middle path, which is about 2 to 5 microns. Same thing shown in this other slide where you find that size which is less than 2 microns usually goes only to the alveoli but will come back. It is the 2 to 5 microns which is going to affect the bronchi and the bronchioles, which is the target area for your patients of asthma. And if it's more than 5, then it's likely to be just, deposited in the mouth, nose, and the upper airway, and again will have no clinical effects. So when you are talking of particle size, that is what the target size would be, 2 to 5 microns. Now, particle size matters, and this has been seen by various experimental studies. And you found that, if there is most of your devices, mind you, which we have, whether it be MDIs or nebulizers or, your DPIs, most of these devices will deliver a heterogeneous particles, which means that the size of the particles can vary widely. And that is why you find that most of these devices will not be able to deliver more than 20% of the dose. So what you give in your puff of say 200 microns, hardly about 40 microns of micrograms will be reaching the lungs and having its effect. And there have been experiments with monodisperse aerosols, which means that basically, a dispersal of aerosols with the particles are of the same size, where they found that if you have a size of particles 3 to 6 microns, the equivalent bronchodilator effect with a beta agonist can be had with 1/10 of the dose. So basically, if you have monodisperse aerosols, then there's a lot of work being done in this area. How we can make the aerosol more kind of homogeneous and of a particular particle size. If you are able to do that, then you will be needing much less dose than even the conventional, the doses that we are using today. And of course, they found that there is no adverse effect on the heart rate or potassium levels if beta agonists are used in these monodisperse aerosols. So this has been shown pretty early. 2003, these experiments were done. And so there is work on world over in the, in the industry where they're trying to find ways of having these monodisperse aerosols in the inhalers. Now let's look at the aerosol generation system, that is the devices. So you have the jet and the ultrasonic nebulizers. Then you have the pressurized meter dose inhalers, which you're all very familiar with, which you may use with or without spacers. And then you have the dry powder inhalers, which can be a unit dose or multi-dose. And let's talk about each of these and the pitfalls with each of these, So let's talk about the most popular pressurized meter dose inhaler. Now you're aware, if you look at the anatomy of the inhaler, that it has a canister, it has a plastic holder. The canister holds the propellant with a drug suspension in a liquid form. There is a metering valve and there is a mouthpiece. When you press the canister down, then under a pressurized it forms the liquid. When it comes out, forms an aerosol, which is then inhaled by the patient. Now earlier the propellants that were used were the chlorofluorocarbons, and we know that the chlorofluorocarbons have been now more or less banned due to the adverse effect on the ozone layer. And that is why these chlorofluorocarbons, which were remaining in the air for a long time, were having adverse effect on the environment, and so they have been banned. And it is the hydrofluoroalkanes which are now used as the propellants in the inhalers. So these new devices are more effective. The HFA propellant produces an aerosol with smaller particle size, resulting in improved deposition in the small airways and greater efficacy at equivalent doses compared with the CFC MDIs. So that is where we are heading for most of our MDIs now. Now, the pressurized meter dose inhaler has got several advantages. It is portable and compact, so you can put it in your, pocket, or ladies can put them in their purses. The treatment time is very short. You can, in a few seconds, you are able to, give yourself the dose. No drug preparation is required, so simply shaking the inhaler is enough. Dose-to-dose reproducibility is very high, so dose does not diminish as you, go down your, inhaler. And there is no contamination of the contents because it's perfectly sealed. However, there are several disadvantages as well, because a good coordination is required. Coordination is required between the breathing and the actuation. So unless that is done, you find that the inhaler can be all over the place. there is a high amount of pharyngeal deposition. So as the inhaler hits the back of the throat, a lot of it is just deposited there. There is a cold freon effect. So, the cold inhaler, when it hits the back of the throat, it can cause a cough. And if in the modern day inhalers, you have the dosimeters, but earlier the dosimeters are not there, so the remaining doses was difficult to determine. There's potential for abuse. So we have known patients finishing their inhaler in one day, because when they panic, they start, sort of puffing every few minutes, and they finish their inhaler, and of course they are prone for serious side effects. And some of the inhalers are still using CFC, but they are very few now. Now this is a new device which is called the autohaler. So it reduces the, so it clears, one pitfall, which was the need for hand or mouth coordination, by firing in response to patient's inspiratory effort. So as soon as the patient puts his mouth here and inhales, the inhaler fires by itself. Now this is very good for patients who are old, who have severe airflow obstruction, patients who have arthritis, who can't, press down on the inhaler properly, and for those who are not able to understand how to coordinate between the pressing down of the inhaler and the inhalation. So in all these situations, the autohaler increases the lung deposition. Now, another device which is used to help in the drug deposition and better drug deposition is the spacer device. Now, this is a chamber reservoir where the actuated aerosol can be held prior to the inhalation. So this is a very nice concept where the inhaled medicine is held in this chamber, and then when the mouth is put into it, the drug can be inhaled subsequently. So there is a lag between the the drug being kept in the spacer while the patient is then going to inhale it, and the drug does not get disseminates in the air. Now this was first developed in 1981, and there have been a lot of such. So you can see here this young girl putting the spacer in her mouth, the inhaler on one side, and as she presses down, this will collect inside the spacer, and then she will inhale from it through a one-way valve. And that makes sure that she cannot breathe in, but can only breathe out of this. So these are various types of spacers, and you have various, sort of models of these spacers which are available. They are all pretty light and handy. However, they have their, pros and cons. So what are the indications for a spacer? In patients who are unable to use the MDI. Also to reduce the risk of adverse effects with inhaled medicines, because we know that the spacer is also able to take care of the pharyngeal deposition. So what was being deposited at the back of the throat is now no more so, and so the risk of oral candidiasis and dysphonia is less with the spacer. And it also decreases or eliminates the coughing because of the freon effect, and you get the you can inhale these medicines during severe exacerbations, as has been recommended by some of the societies. So the advantages are the reduced need for patient coordination, reduces pharyngeal deposition, and reduces the cold freon effect. But it adds to expense, it is less portable, can reduce dose availability if it's not used properly. Some of the patients still find it very complex to use the spacer, and patients find it embarrassing to carry their spacer around and use it in public, because it is so visible that where they could just slyly go to one side and use the inhaler, but now they can't use the spacer in public. So that is another disadvantage. Now this is a zero stat spacer which has been recommended by some of the companies, and basically this takes care of the deposition of the drug within the spacer. So unlike where the MDI was depositing drug in the pharynx, in the spacers which had significant amount of static elasticity, the drug would get deposited on the surface of the spacer. Now the zero stat spacer takes care of that and does not allow the drug to get deposited on the inside of the spacer. So this is another innovation which is being used. Now the dry powder inhalers, the DPIs. Now I personally am very fond of the DPIs because you both have the single dose and the multi-dose. We are aware that, example, the devices shown above have capsules which are single devices. You have the turbohaler, which is a reservoir device, and then you have the singlet devices like the the seretide or the Seroflow inhalers which are there. Now, the breath powder inhalers are breath actuated, so no coordination skills are required. They're easy and convenient to use. No propellant is there, so they are environment friendly. However, what is the disadvantage? It requires a good inspiratory effort. Now, mind you that unless you are able to pull these devices properly, the drug will not get in properly. Carries a single dose at a time. Capsule and drug life reduced by moisture and humidity, so you have to carry the capsules separately and make sure that they are not sort of exposed to moisture. And this can also result in a high pharyngeal deposition. So there are pros and cons. However, I find especially for old people, especially for people who have severe hand, mouth coordination, it's a good idea to use a DPI. Now, lastly, the nebulizers. Now, this is something which has been used a lot in critically ill patients. However, also in some of the patients who are being treated at home. There was a nice review article by Deepak Talwar in one of the Lung India issues recently, where he talked of how the nebulizer can be used even for our, earlier it was thought that the nebulizer should not be used. It was taboo to use the nebulizer for, patients on home care. But yes, I find it in my own, practice that, some patients are most comfortable only with the nebulizer. They are very, very uncomfortable with the inhaled devices, and they are more comfortable with the nebulizer, and they do a better job on the nebulizer. And now some of the longer acting, beta agonists and corticosteroids formulations are available on the nebulized therapy. So you have that option. Now, this is easy to use, so even a child can use it, or maybe a 90-year-old person can also use it. Now, let's look at these devices. You find that the nebulizer gives about 15% of the dose. The MDI spacer gives the maximum, around 20% plus of the dose. The MDI only about 10% of the dose, and the DPI also about 20% plus of the dose. So you find that, the drug which is going into the lung is basically, depending on the device. But how do you choose the device? Which is the best inhaler device? Now, I particularly think is the device that the patient can use the best is the best device. And so what do? Ask the patient what he is comfortable with. Make sure that when you are prescribing a device, you are able to understand the individual choice of the patient, what he is most comfortable with, what is his intelligence level, is he able to understand the nitty-gritty of how the inhaler should be used. Otherwise, there is no point in prescribing an inhaler which he can't use properly. So that is very, very important. And then, of course, it is very important to show the patient the correct sort of inhaler technique so that he may follow that and then continue to check it from time to time. Now, you find that age is a big determining factor in finding out, which is the best therapy. So in children less than 2 years, perhaps the nebulizer is the best. 2 to 5 years, you may consider an MDI with a spacer with a face mask. Children more than 5 years, a DPI or an MDI with a spacer if it's an intelligent child. Otherwise, this second option can go on for another 2-3 years. Children more than 10-12 years, yes, surely. They mostly will be able to understand MDI or DPI. And very old people, again, you may have a DPI or a breath actuated MDI, and again, I would say nebulizer. So at the extremes of age, I would think nebulizer works very well, and also for some of the patients in the middle range. Now, what are the other pitfalls? So drugs can have their individual side effects. So, for example, beta agonists can cause tachycardia, tremor, muscle weakness, hypokalemia, especially if you are overdosing yourself. Then inhaled corticosteroids. So if there is a continuous deposition in the oropharynx and the patient is not, swelling his mouth after the inhaler has been taken, then oropharyngeal candidiasis, dysphonia, cough in some patients in high doses, and very high doses, then you can have systemic side effects like bruising, decreased bone mineral density, cataract, glaucoma, etc. if you are using the high dose ICS for a long time. And then anticholinergics, dry mouth is a common complaint, both with the longer acting, muscarinic agonist or the antagonist or the even the short acting ones. And sometimes we have seen urinary hesitancy if there is an overdose of anticholinergics. Now, what are the patient factors? We have talked of the aerosol factors. We have talked of the devices. What are the patient factors? Now, as we already mentioned age, which is an important determining factor in terms of which device should be used. We have also talked about muscle strength and coordination. So very small children and very, old people, you may have problems with coordination. The inspiratory flow rate. So in a very patient with severe COPD, for example, who has a very low inspiratory flow rate, he's probably better off either with a nebulizer or with a MDI, but a DPI device which requires a high flow rate, inspiratory flow rate, won't be able to use properly. And then there are myths. So, some patients will not use inhaler therapy because they are too scared of the myths. So we'll talk about that. And of course, you have to understand the techniques and the precautions. So let us go on ahead. Now, just look at this video.
They said they'd fix it, but it didn't make any difference at all.
Well, sometimes doctors make mistakes, and you need to try twice as hard to fix them. Are you using your inhaler?
All the time. Go through one a week.
Are you sure you're using it right?
Do I look like an idiot?
No. Why don't you show me how your inhaler works?
Sure.
So basically, I've actually seen this happen. So I remember I was in Saudi and there was a 16-year-old girl who again said that her asthma is not in control. When I asked her how it is used, she sprayed it just like this brilliant lady who was sure that she's not an idiot. So it's not her fault. Nobody has told her. So basically, she's just using it like a deo. So unless somebody tells her, somebody explains to her how it is to be used, that's the only way she has seen, aerosols work. So somebody has to explain them the technique, somebody has to explain them the precautions, somebody has to explain them, how to get the best out of your inhaler or your device. What are the myths? So there are myths. You have myth number one, inhalers are addictive. So, a lot of Indian patients, they believe that, if they are given an inhaler, they are stuck to it for life. So you have to explain to them that the inhaler contains exactly the similar medications which are there in their oral therapy. And by no means is it addictive. It will be given for as long as is necessary, but they can always come off the inhaler if their asthma is better or controlled. So you have to, break down this myth number one that inhalers are addictive. What is myth number two? Inhalers are meant for very severe disease. Oh, doctor sahab, मेरे को आपने inhaler दे दिया, मेरे को इतनी problem थोड़ी है. So, a lot of patients believe that they should be given the inhaler only if they have severe disease. And using the inhaler means that that's the end of life for them, because that means obviously they have very severe disease and perhaps not long to live. But that's again a myth, because we know that inhalers are given for the mildest disease, not for the most severe disease. You may continue to use the inhaler right through all the steps as the GINA guidelines have shown you. So, you have to break down these myths. You have to explain to the patient why the inhaler is necessary and perhaps the best thing for them. And then age, as I said, to determine device. If it's an old man who's not being able to use the inhaler properly, he will be so much more comfortable with a nebulizer. So basically, you have to determine what suits your patient best. That is the main thing, I would think. That is the take-home message today. And then, of course, patient education to ensure compliance. So unless the patient is being given proper education again and again, you cannot be sure that he will be using the inhaler therapy and will not fall into one of the pits which are there for the inhaler therapy. So to conclude, inhaler therapy is one of the most important advances in the treatment of asthma. There are a lot of choices amongst the drugs and devices which can be used for this purpose. There is no perfect device, and the delivery to the lungs is only around 20% of the dose delivered. Proper selection of the device to suit the patient, and then educating him regarding the technique, the need for compliance, and removing any apprehensions are essential to maximize benefit, and constant monitoring of the technique and compliance must be done on a subsequent visit. Thank you very much. Thank you, Gaurav, and thank you, Dr. Chawla, for giving me this opportunity. And I come to the end of the talk, and I'll be happy to answer any questions if there are there, and we can take it from there.
Thank you, sir, for enlightening us on this very important aspect of asthma management. The correct inhaler technique is a very must thing in the asthma management. So now we move ahead into our last talk, next section, discussion part. So where we'll be taking the question and answers from the audience. So I would like to hand over the dice to Dr. Rakesh Chavla, sir, our moderator, to take up the questions through the speakers. Sir.
Thank you, Gaurav. Before I take up the questions from the audiences, they are there from Chennai, from Chhattisgarh, from Delhi. I will like our chairpersons to have comments on the speaker's talk, or if they have any queries, they can ask directly or give their comments. So first priorities of our chairpersons, I will be very happy to listen them, or I am ready to have their comments. Any chairperson, all are welcome, sir.
Good evening, sir. This is Hitesh Agarwal. Can you hear me?
Yes, we can hear you. Welcome.
Yeah, sir. Very nice presentation. Very nice. It was very easy to understand, and I think it will be fruitful for all. So, looking for future ventures also in these very common topics, which are very important in day-to-day life, professional life, and personal life also.
Thank you.
Thank you, sir.
Thank you, Hitesh. Okay, so there is a question from Dr. Sundaramurthy from Tamil Nadu. Professor Jindal, sir, how common is asthma in twins? Sir, unmute, please. Sir, unmute, please.
Yes, sir. Yes. How common is asthma in
twins?
Twins.
Right.
Well, there is increased incidence. I may not be able to tell you what the exact percent, but certainly there is increased incidence. That's all I can say. Maybe double the chances than the normal people. You see, I don't think it's a necessity to have. There is also a difference between homozygous and kind of non-homozygous twins as well. But I don't think that it is a must, you see, as far as I know.
Correct. Our Delhi colleague, Dr. Amardeep Sachdeva, she wants to know anything about allergy testing, sir? Any benefit of allergy testing and immunotherapy?
Well, certainly, allergy testing is one of the modality which has been done and which had been common in the past in children in particular. I think in allergic type of asthma, it is one of the type of modality. But I think as of today, it is not the most common kind of practice, you see, which is used, partly because of the complexity of the treatment, you see, that once maybe the other types of immunotherapeutic agents become available, either subconjunctival and straight, perhaps it may become more common. But I will not say, because the very effective drugs are available, and now with the biologicals. So immunotherapy is not the preferred mode, because there are multiple allergens also. That is the other problem in adults. So they say, how many allergens can you really desensitize? So, but I am sure there are many people who have very good experience, including in this country, in Delhi, etc. If it is a specific type of allergen, for example, hay fever, or when the allergens are grasses and other things, good results have been reported. But overall, I think in adult practice, clinical practice, it is not a very common mode of treatment employed.
Correct, sir, because I personally experienced of the things is that extrinsic and intrinsic asthma, you cannot, they say allergy can be from under the sun and above the earth. So extrinsic, where you are able to pinpoint some of the antigens which trigger, are the patient, if you are able to get it, you are going to get a benefit. If the patient is allergic to endogenous proteins and the intrinsic pathways, so allergy and immunotherapy has got a limited role. You made the topic very difficult but made it very simple. There's a question from Chhattisgarh. He says the future of phenotyping in asthma like RNA transcriptomics is the in thing. What is this, sir? RNA transcriptomics like bronchial asthma tissue, bronchial in the blood or in the sputum?
I think maybe he's talking phenotyping based on molecular mechanisms, but perhaps I have to really go through that phenotyping. There is no, as of today, I don't think it is a very, it may be experimental, I'm sure, in some investigators' hands, you see. But certainly based on different genotypic methods or molecular mechanisms, the phenotyping has been tried. Being tried, that's all I can say.
Very good. Thank you, sir. What about Manoj? What do you think about GINA? What is new in GINA 2021? We are talking about GINA 2002. How it is different from 2020, 2019? There's a question from the general physician. He wants, and I want you to answer simultaneously from our Dr. Dhamija, azithromycin role in step 5.
After a long time, Dr. Chawla, the GINA guidelines have been really redefined because the two-track system available, where they have talked about the smart therapy, and one is where they are just giving step 1 and 2, maybe the short-acting bronchodilator, and then with inhaled corticosteroids. So that is one thing. So now it is generally believed that the smart therapy, that even in step 1, the inhaled corticosteroid is the mainstay of the treatment. So ICS now becomes the mainstay of the treatment in asthma management. So that is the biggest, difference between the two. They've also, clearly defined the various symptoms on the asthma control criteria, which are, there in various steps from step 1, 2, 3, 4, 5. And they're, mentioned over those steps. So one can just, have a picture of that GINA guideline in your clinic. And then at the same, clearly you can identify what group or what stage this patient, what step this patient is, what kind of treatment he may require. And of course, the COVID guidelines, which are absolutely new, which were not there in the previous, GINA guidelines. So these are some of the important, aspects of, the GINA 21. As far as the management of severe asthma is concerned, there is no difference from GINA 20 and GINA 21. The management of, the biologicals, the bronchothermoplasty, the add-on therapies, that the macrolides remains the same between the two. So the two-track system, which is there in GINA 2021, is the real difference between the recent the GINA guidelines and the previous ones.
And inhaled corticosteroids remain the cornerstone of the treatment of asthma even in step 1. Correct. What about azithromycin? And what dosages should be given?
Azithromycin is basically, as we talked about, that neutrophil predominant asthma, where there could be some role which is non-allergic type, and there severe asthma which is not under control, azithromycin can be used. The doses can vary from 250 milligram once daily, but there is a caveat: patient, we must do a ECG in these patients. We must warn them about the possible side effects, especially the ototoxicity, the vertigo. These things have to be monitored. QTc interval has to be monitored. People with pre-existing cardiac disease, we have to be very, very careful while giving azithromycin therapy. So the dose, we can start with 250 milligram daily. Then as the patient improves, we can make it alternate days and see how the patient goes. So that is a very specific small group where the azithromycin can be used as an add-on therapy in severe asthma.
So correct, in neutrophilic and polygranulocytic phenotype of asthma, it may be useful. Our senior from Rohtak PGIMS, Dr. C.K. Mittal from Ambala, he's asking ICS to continue even once the asthma is absolutely stable and patient is all right. And if you have to continue ICS, till how much? How much duration you need to continue?
You want me to take this question?
Anyone can take it. Anyone. Okay. Rajiv, will you like to answer? Professor Jindal, sir.
I think the treatment, although the most of the recommendations would say that it should be continued almost forever, regularly, on regular basis, you see. Of course, there is a step up and step down treatment, you see. So some kind of the doses reduction can be done and a maintenance treatment can be continued. But I will also say that one can use one's own judgment. If patient has very limited period of symptoms, you see, during only change of season or for other allergic seasons, I would say that perhaps for few weeks to few months it can be continued and then stopped, and maybe the next year again it would be required. Otherwise, that the inflammation does not go. That we all know that it is not a permanent treatment, and retreatment would be required. And some patients require continued maintenance treatment, you see.
I can add to Dr. Chawla. The thing is, now mild asthma is again has to be taken seriously. The time has gone where one would feel that mild asthma is not dangerous. One can have a severe exacerbation. They are equally prone to have severe exacerbation as a patient who doesn't have a mild sort of category of asthma. So, as a matter of fact, inhaled corticosteroid therapy, in my opinion, should be continued as much as possible. And if the patient goes off inhaled corticosteroid therapy, these patients have to be monitored very, very carefully. Maybe their asthma control, ACT scores and all, and maybe periodic spirometry must be done in these patients. They must be in regular checkup, and especially the vulnerable patients, where the patient who is not likely to follow up with you. Maybe it's a good idea to keep, them on inhaled corticosteroid therapy as much as possible.
Rakesh, can I put in a word?
Yes, you're welcome, sir.
Yeah, so basically, I would, lean more towards what Dr. Jindal said, that you have to individualize the therapy. And it's a question of which particular, sort of the severity of the patient, whether it's a seasonal asthma or whether it's a, continuous persistent kind of asthma. So that is what is going to really decide how long you're going to use these inhaled corticosteroids. I have seen I don't know if some of the others I'm sure have seen. Dr. Atul Mehta once showed what inhaled corticosteroids can do to the airways, continuous use of inhaled corticosteroids. So, it's right that they should be given, for as long as is necessary. But then what is necessary is also a question for the physician to decide. And in that context, I think that although you would want to give them for, long periods of time, but in a patient who has very, very, seasonal, very specific, there are so many patients who come to you only in April or who come to you only in September. And it is in that kind of patient, there's no reason to give them, continuous inhaled corticosteroids. You would treat them for a few weeks, and once they are better, then you send them home without treatment and tell them to, sort of resume treatment when the season arrives. But then there are others who have symptoms, on a continuous basis, and where what Manoj is saying is more pertinent, that you would continue to treat them and so that they don't, fall more sick. So I think it's a question of individualizing therapy. It's a question of, using the therapy judiciously and monitoring your patient, and maybe also educating your patient that at the slightest of symptoms, he should, report. So that is perhaps the best way you can, have a communication with the patient. So I would think that would be my answer to this question. Yeah.
Very nice. I want our postgraduate, Dr. Ashish, to put in. He's raising his hand.
Thank you, sir. Sir, I would like to know what should constitute mild asthma, sir? What would mild asthma constitute, sir?
Manoj.
Anybody who is in step 1 and step 2 would be possibly a candidate for mild asthma. The person who is not presenting with severe symptoms, person who is not presenting with recurrent exacerbations, person who is not requiring high dose of inhaled corticosteroids, a very small dose of inhaled corticosteroids maintenance therapy. So, and again, symptomatology wise, what is the frequency of those symptoms? Possibly, as I remember, maybe somebody who's got symptom less than once in a month possibly would be once or twice a month would be considered as having a mild asthma possibly. So this is my answer to it.
I think sometimes people tend to go by the GINA guidelines as a religious textbook, you see. That's not always so. Basically, these are guidelines. You must remember that asthma in the past was classified as mild, intermittent, severe. And then there is persistent, mild, moderate, and severe, and moderate, persistent, moderate, intermittent. And that still has a clinical relevance, I would say. You may not be able to strictly define and classify these patients into one or the other category. But in your own clinical practice, we have large number of patients, these patients who would come, certain medical students, doctors themselves, they get 2 or 3 attacks every year during change of season, and then it is okay. That is also asthma, ever asthma. You see, that's why it is difficult to classify asthma or define asthma, ever asthma, then persistent asthma. So anybody who gets relatively occasional episodes of asthma, nuisance asthma, which sometimes has been called, you see, and who does not require hospitalization. That is what is mild asthma. And these are the patients who would require inhaled therapy only for a few weeks to few months every year, you see. And whether you really prescribe for constantly, they will not take it. So that also is effect of clinical practice. So mild asthma is anybody who gets occasional attack once or twice in a, for example, in a year, or seasonal episodes, you see, and does not require hospitalization, who does not show airway obstruction in between the periods, who responds very well to inhaled corticosteroids. So you can define these criteria. So it may not be a rigidly defined classification based on the GINA guidelines or the guidelines, but in clinical practice, I think one always sees such patients, you see, and using your own wisdom, you can always classify these patients who are severe, who are moderate, who are mild, and who need intermittent therapy, who need continuous therapy. I will always go by that. It's not necessary to continue therapy in such patients. Although I always say that don't take only for a few days. You see, once you are prescribed inhaled treatment, inhaled corticosteroids, take at least for several weeks during that season, so that the recurrent attack does not come, and then decrease the dose, step down the treatment, and once they're okay, stop the treatment.
Correctly, sir, guidelines are to guide, but you have to use your common sense when you are treating your patient, and you still the old is gold. A correct question of mild, moderate, and severe asthma, which we have been handling since years. Rajiv, the exhalation is very important part of the technique. In one study, more than 98% of the patients claimed to know how to use inhalers, but 94% committed mistakes. So the training part is very, very important. Do you agree? In spite of the patients, doctors also need a training to teach the patient a correct technique. Are you sure that all our general physicians who are treating this population in large are trained how to use the inhalation technique, and how you will like to address this message to the general physicians who are into this webinar?
Yeah, I think just like you quoted figures about patient, there are similar figures regarding medical personnel as well. So you have lot of doctors who believe that they know the right technique, but when actually tested, they are found wanting. So I think that training the trainers is as important as training the patients, and for sure there is a real need for making all people who are treating asthma aware of the ways the different devices are to be used and how to get the best out of the device. I think that workshops and your conferences and your uh, seminars that are held, they have to dwell on this very, very important part, because just like you have felt it important to use this as part of your, of your symposium today, the inhaler technique is actually where it matters most, because if the inhaler is not taken properly, then it really defeats the whole purpose. So my feeling is that you do need to train people. You need to train doctors, nurses, and everyone concerned. And what I normally do is to, in my clinic, as soon as the patient goes out of the clinic, there is a person waiting outside who will actually talk to the patient, even if he has talked to him many times before, and just checks the inhaler technique. And I in fact encourage my industry colleagues, these our MRs who are coming to visit me, to sit there and help me with that, because they sit there and actually teach the patient how the inhaler is to be used properly. And that helps, because if the patient is taught properly, you may use posters, you may use, you may time to time and make sure that the patient is understanding the technique, just like the video I showed you, where the patient, is spraying herself with the inhaler rather than using the inhaler. So you need to make sure that the patient will take the inhaler properly, and you also need, the general physicians and physicians who are treating these patients also need to be sure that they know how it should be used. Yeah, it's a good point.
So we are now near closing because the time is getting over. All of us have already devoted more than 2 hours. So I give now the opportunity last to the chairpersons to comment. Dr. Chandramani Punjabi, who is in Mata Chanan Devi HOD, he wants to have some comments. Welcome.
Yes, so first of all, sir, thank you very much for the invitation. So I wanted to make a comment on azithromycin. So a few months back, the BTS has released guidelines on long-term usage of macrolides in chronic respiratory diseases. And they have covered diseases like asthma, COPD, bronchiectasis. So they are over and above azithromycin for acute exacerbation of asthma. The BTS says that those patients who are the neutrophilic phenotype and they respond to azithromycin, we should use pulse therapy of azithromycin for 2 to 3 years in those patients. And 2 regimens they have suggested. It is either thrice weekly, every to be continued for 36 months, or it is 500 milligram for 3 days to be repeated every month for 2 years. So I think I will post that guidelines in the WhatsApp group. I think every one of us can read it and we can get more information.
Correct, absolutely correct. The pulse therapy of azithromycin is recommended, and I think it's a good enlightening point. Any other chairperson? Yes, Dipender, please, you are welcome.
So very good evening, everyone, sir. Sir, I have just one query. As we all know that the asthma patient really don't accept that this disease is curable. This is not curable, and you have to take the medication for lifelong. And Gina highlighted in the last few years, especially treating the mild asthma patients with regular treatment or with treatment with ICS formoterol combinations. So what should be the frequency of the symptom after which we can start this ICS LABA treatment or ICS formoterol treatment? And what is the current situation of retained asthma plan? That is also very much highlighted by the Gina. But I don't think we are following these retained asthma plans very frequently. So what could be the reason for that? So these are the 2 things I have asked for that.
Manoj, you will take?
Yeah, so as I also said, we have to take even mild asthma very seriously, and these patients must be under follow-up. And how they can be kept under follow-up is, as Dr. Pinner talked about, by giving them an asthma action plan, which is actually not very difficult. The asthma action plan is just telling them what symptoms and what stage they have to escalate their therapy, the reliever therapy, and the controller therapy, and maybe oral corticosteroids. So that becomes very, very important. This asthma action plan has to be explained to the family as well. And I also feel that somebody in the family must be, looking after these patients very carefully, their symptoms, because these patients would have symptoms, would not, feel for them. And when they come back to us, then maybe they're in a got a fixed airway obstruction, which is not uncommon as a matter of fact. So now coming to the point why asthma action plan is not implemented or is not given by the physicians. I think we are culprit. We must accept that this is something which is the core issue in the GINA guideline. We must address it. And I think with 2021 guidelines, where even for COVID infection, there's advising for the asthma action plan. It's very important that we incorporate it. We can say that we are very busy practitioners and we don't have time. It's very difficult to do it in a country like India where you're seeing 100 patients. But I think we have to develop a staff, the infrastructure. You have to train our fellows. Even a nurse can do it, a technician can do it, and we can have again we can ask the industry to give us some pamphlets where a written plan is there which we can hand over to each and every patient. So that can come in a long way. We can make some CDs which we can offer to these patients. If not at all. I mean, this becomes a very important aspect, because if we talk about the inhaler therapy, but giving an asthma action plan is also equally important from the asthma management point of view, because it's a chronic disease, a lifelong disease. Asthma never goes. I mean, I believe that asthma never goes. Whatever it is, patient may be symptom free, but it never goes. It can come back and it can hit, and it can hit very hard.
So do you think that the mild asthma patients for our region is different from Western regions as far as the severe exacerbation, the frequency of severe exacerbation is concerned, or the frequency of hospitalization for the mild asthma patients, so that our treatment would be different in compared to Western data or GINA guidelines? Our guidelines should be different, considering poor education, poor literacy. They are not really accepting the disease is not curable. You have to take the lifelong. It is very difficult to really convince them. They are more comfortable to take this montelukast tablet, and that would be effective compared to this inhaler therapy. So what is your take on that?
I think Dr. Rajiv Goyal can take on that.
Rajiv, sir. I think he must be busy. See, you have picked up a very, very important and a very good point. We talk when we give lectures, and I tell we, especially in our system, as Manoj has agreed completely, the asthma action plan. Maybe somebody says I follow. I can sure 99% chest physicians do not follow. They only talk about it, right? And as you said correctly, inhalation therapy is still a taboo, still a myth. Even educated people doesn't want to use it. They are happy with the tablet of theophylline or a little amount of steroid with montelukast rather than opting for an inhalation therapy indefinitely. And this is absolutely correct. There is no doubt about it. So if you say GINA does not recommend it, but how the patient is comfortable, whatever way he is comfortable, I think we have to take it.
Rakesh,
comments, yes.
Rakesh, let us not be nihilistic.
Yes.
The awareness for inhalational therapy is much more than before. You see old ladies from Haryana coming from the village using the inhalers. So it's not as if things are not changing. And first and foremost, we must be convinced in our own minds that this is the way forward. If we are convinced, then we will convince our patients also. So I don't think that the message from this meeting should be that you completely, go according to the patient's wishes. We have to make sure that the patient understands that this is the way forward and that is the best treatment. And if we are emphatic enough, he is bound to follow. And he may make a mistake once or twice, but then he will, fall onto the right path. So I think first and foremost, like Manoj said, it's a lifelong problem. And you have to make them aware of the fact that what is the least harmful medication out of all these for a lifelong problem, which is the inhaler. So you have to make them aware. It's not that the patient does not understand the benefit of what is good for him, but it has to be done in a convincing and an emphatic manner. So I don't think that we should, fall prey to this notion that patients will not understand or patients will not listen or patients will not, even if they are illiterate. An illiterate person also understands what is good for him. So, you have to drive the point home. You have to be emphatic and you have to explain how it is easy to use and perhaps even cheaper to use. So, I think that at least for all the people who are attending this webinar, wherever they are, we must be very, very clear in our own minds that if anything has changed the treatment of asthma, it is inhaled therapy. So you have to be very, very clear about that.
Absolutely correct.
Last comment, sir. Just a last comment. So these are the type of the patients for which the physician give a very less time if you compare with the other disease. And ideally, this group of the patient require more time. That is something which is treatment beyond the prescription, and we have to give the time. So I just request all the audience physicians to give the time to such patient. It's not just inhaler therapy. You have to change the inhaler therapy. You have to educate the patients. That is very important. You have to counsel the patient regarding disease course, or it is not curable, or everything you have to tell. So just spend the time for such type of patients. There, the patient physician generally give a 1 minute for such type of patient. That is totally not acceptable. Those patients who have a poor control, even in that cases. So this is the last message. Thank you very much, sir, for giving me opportunity to be part of this grand conference. Thank you.
That is well said. That is true not only for asthma. It is true for all diseases. So you have to give time to the patient.
I will ask the audience that you must devote time, as you said, action, asthma action plan, give time, inhalation technique, and they say every time when patient comes, you must observe. Don't say the patient says that he knows the technique is correct. Ask him to demonstrate every time. And there will be one or the another step he will be missing. So time has to be given to the patient. Inhalation treatment is the way forward. There is no doubt about it. There are still so many questions are in the line. Already we have crossed the time. So I think I thank all the chairpersons, especially Dr. Jogesh Sharma from Guwahati. I am able to see him after so long time. So I thank you all the chairpersons visible with us, agreed to accept, and there is a good audience on the other side. There are still so many questions left. So I thank everybody. Thank Professor Baheda to inaugurate this. Dr. Krishan Bihari Gupta, my teacher and my colleague in the initial days for 2 years. Professor Jindal, the stalwart, Professor Rajinder Prasad, to help and inaugurate the webinar series. I'm thankful to them. Maybe we are a little beyond time today, but next time we are going to start straight with the time. So there should not be that we are crossing our time. Thank you very much, sir.
Thank you very much.
Again, from the bottom of my heart, I am thankful to everybody, sir. Thank you very much, sir.
Thank you, Dr. Savla, for your good winnings.
Thank you, sir.
Thank you, sir.
Your beginning is very good.
Thank you, sir.
Thank you, sir.
Thank you very much, sir. Thank you, sir.